Thank you, Dr. Rohan. And so I'll be speaking on imaging in uveitis and what all it may help in management. And so we already know that uveitis is just not the inflammation of the uveal tract and can also involve its adjoining structures. So we need a comprehensive assessment of all the structures to get to a diagnosis. Also, same diseases may have different manifestations. So similar, same disease might present as a anterior uveitis, might present as a posterior uveitis, and likewise, different diseases may look similar, and some of them may also have an overlap, like white dot syndrome. So often enough, it is confusing, and we need everything and uh, anything that will help us to reach to a diagnosis. And it's since uveitis is a chronic entity, we need also on follow-up to pick up reactivation and complications. So basically, we need imaging for all these things. And the imaging that we have at our disposal are these, and some of these have already been discussed. So we'll just move on with one investigation at a time, and then we'll discuss few cases. So how does OCT help? Well, we've already discussed how OCT helps. How it helps in uveitis? Well, it helps in stratifications, as everyone else said, and it shows which layers or maybe which layer is involved specifically, and we get a very meticulous evaluation of the structure involved. So as we can see, where we can look for these vitreous cells that are there, posterior vitreous cells. We can look for a CME. We can look for all these subretinal fluid with subretinal fibrin. We can see for choroidal thickness, some hyperreflective material. And in cases where we do not have an access to the, not access, but we can't see the anterior chamber, in cases of corneal opacity, we might even look for some activity in the anterior chamber with the help of an ASOCT. In case of FA and ICG, well, these help us to in telling whether whether the disease is either localized or it is generalized. It also helps us in telling at which level it is, either in the retina or the choroid. It can help also and guide us in management. If we see the NBs or large areas of CNPs. So a few examples, as we can see in the first photograph, we get this typical fawn type pattern, which is seen in Behçet's. We get these hypo spots, which we see in white dot syndromes. A disc leak that is there, which is seen in disc granulomas, can be seen in sarcoid, and a petaloid appearance with the CME, and these small aneurysms that are there along the arterial vessel, which show it's an IRWAN, and and obviously CNP and NV, which will guide our treatment. Going on to OCT, well, OCT has been discussed widely now, and the different thing that it shows in uveitis is basically shows flow deficits, which can be actually localized to either the retinal or the choroidal layers, and it also at times shows response to treatment, and it is the modality of choice for diagnosing a CNVM, which is an associated complication. Autofluorescence, well, it gives you the structural functional status of the RPE, and all the diseases that are involving the RPE will show activity in case of increased metabolic activity. And these also tend to show the lesions far better delineated on autofluorescence in comparison to other modalities. Now, this was a basic thing that what all we see on different modalities. Now we'll be taking up a few cases. So either we can do, we go for investigations when we want to confirm a diagnosis and we already had a suspicion of it, or for basic documentation to see how it is responding to our treatment. Also, we tend to do it in cases where we are not sure of the diagnosis and we need additional investigations to help us to come to a diagnosis, and in cases of follow-up where we can actually guide the treatment according to what we get on these modalities. So first, going to diagnosis confirmation. So the first case is a very simple case, and it was referred to our neurophthal clinic for disc edema. And on examination, retrodental cells were found, and they was referred to us. It was a case of intermediate uveitis, and when we did OCT, you can see that there is a CME. Then another case. Now we'll be discussing a few cases in relation to retina. The few the first case that we discuss is, as we can see, there's a focal retinitis patch with the arterial involvement and a serous detachment. And on OCT, you can see that there is hyperreflectivity of inner layers as well as some places all the layers. So this is a case of a toxoplasma chorioretinopathy, and when we give treatment, you can see that there is resolution of this focal patch of retinitis as well as decrease in reflectivity and thickness, and with time it actually make becomes a hyperreflective scar. The next case of focal retinitis is where we see these focal retinitis patches with few hemorrhages. You can see a macular star and a serous detachment at the posterior pole along the supratemporal arcade. Well, you can, this case, we diagnose it as a neuroretinitis, and it is aided with the help of OCT, where we can see these posterior vitreous cells and the hyperreflectivity of inner retinal layers and an NSD. And with treatment, as you can see, there is resolution of the retinitis. Another case of focal retinitis in which you get a plaque like a retinitis with some with hemorrhages as well as tortuosity of vessels. On OCT, it helps us to see this separation of ILM and necrosis of the retina, which is typically seen in a viral retinitis. So with antiviral therapy, you can see the resolution, and in the end, you can see the scar that is formed. Then we are going to go to another case in which we see a yellowish spot at the fovea. And when we do an OCT, we can see this hyperreflective material that is there at the level of the photoreceptors. And this is diagnosed as a case of acute retinal pigment epitheliitis. And with treatment for that matter, it also at times regresses spontaneously, and you can see that there's reduction in the hyperreflective material. Then another similar case where you see these creamy flat lesions at the posterior pole with disc edema. On FA, you can see the late hyperfluorescence with disc edema. On ICG, you can see these hypospots with, and on OCT, you can see this disruption of photoreceptors and RP, which is seen in the case of APM PPE. Then again, if you get a case in which you are seeing these multiple serous detachments with early hypofluorescence, with few pigment leaks and late pooling, as also was shown by Dr. Neha, you are seeing a case of VKH, and here you can see the multiple NSD with a subretinal thickening. Then again, if you see a case in which you are seeing these geographic creamy colored lesion with an advancing edge and a disc edema, and the other eye shows a healed choroiditis patch with a central scar. When you do an OCT, you see that the scar is a CNVM, and you can see the activity on OCT on of the left eye as well. So this is a case of a serpiginous choroiditis. Moving on to a few cases of vasculitis. As you can see, this is an active vasculitis with cuffing of vessels, hemorrhages, and disc edema as well. To see which type of vascular involvement is there, we can go ahead with a FFA, and we can see that it's mainly a periphlebitis. It could be a sarcoid. On treatment with steroids, you can see that there is resolution. Moving on to the next case. Well, you can see there's some media hazes there, there's vitritis, and there's a focal patch of retinitis with a hemorrhage. But when we went ahead and did a FFA, you can see these perivascular hyperfluorescence, and in late phases, it increases to a typical fawn pattern, which is suggestive of a Behçet's disease. Another case in which you see this NVE that is there along with these twisted arteries, and when you go in for an FA, you can see that these are the arterial aneurysms that you see at mostly noted at the bifurcation of these arteries, and you get a diagnosis of IRWAN. Going on to another case, here we see that there is retinal whitening and associated some vitreous hemorrhage. Whether these are cotton wool spots, no, but this is a Purshar flecken, which is seen in cases of Purshar's retinopathy, commonly associated with trauma, but it can also be associated with collagen vascular diseases, where it is called Purshar-like retinopathy. As you can see on the FA, there is only peripheral perfused retina, and rest is all capillary non-perfusion. Then another case in which we see a focal yellowish lesion that is there at the posterior pole, you might diagnose it as a choroiditis, might diagnose it as a CSR. And when you see it on OCT, there is increased choroidal thickness with some subretinal fluid and posterior vitreous cells. And you come when you do go ahead and do a USG, you can see there is increased choroidal thickness with the suprachoroidal fluid, and you have come to a diagnosis of posterior scleritis. So these were ones which we already suspected the case, a diagnosis, and we just confirmed it. Then we go on to some few diagnostic dilemmas. Well, the first case, we see these retinochoroidal folds, some infolding of the retina is seen, disc edema is seen, there is a foveal fold as well. On OCT, you can see these vitreous cells, obtunded disc and foveal fold. And when you do a ultrasound, you can see that there is increased choroidal thickness with a suprachoroidal fluid, giving you a T sign. With treatment, you can see that it has resolved. Another case in which you see this yellowish spot at fovea, as I showed you before, and on OCT, you can see this hyperreflectivity at the level of the photoreceptor and the RP, and you're thinking that it is probably a diagnosis of acute retinal pigment epitheliitis. And with time, you can see that it has now transformed into a geographic lesion, and more with loss of photoreceptor, with the thinning, more suggestive of a macular serpiginous choroiditis. Now, another case in which you get vitritis and you get these patches at the posterior pole, and when you go in and do an OCT, you just find these subretinal RP deposits with the intact Brooks membrane and no CME, and then you are seeing a case which is not exactly uveitis, and it's a masquerader. And when you go ahead and do a FFA, you can see these leopard spotting suggestive of lymphoma. Then lastly, going to follow up, well, we can look for activity, like in this case, we can, fundus autofluorescence can show some hyperautofluorescence, which might show activity. Then going on for documentation of resolution, in which you can see that the serous detachment has now resolved. You can see for treatment response, this case of IRWAN, in which we did photocoagulation and now it has resolved, or else when we need to go in for additional treatment where there is still persistent NVE and we need to augment it with laser. So thank you. And lastly, as you can look for complications on an OCTA, like I said, the CNV. Thank you.